Welcome everyone to our third in our webinar series sponsored by Got Transition, and today's session is going to be on transfer to adult care. And we're very pleased today to have with us Karen Rundall and Lee Gordon from the Kentucky Commission for Children with Special Needs and Kathy Rivers from the Coordinating Center in Maryland. Look forward to talking with you. Next slide, please. So none of us have any disclosures to report to you, and Got Transition is a program that is operated by the National Alliance to Advance Adolescent Health and is funded by the Federal Maternal and Child Health Bureau of the Health Resources and Services Administration. Next slide, please. So the goals of this 5-session series are to support state Title V implementation and measurement of healthcare transition in their care coordination programs. We also hope to guide care coordination improvements by sequentially building on the evidence-informed 6 core elements of healthcare transition, share promising practices, as you'll see today, from 2 states. And the webinars and handouts for each of our sessions are available on our gottransition.org website. So today, at the conclusion of this session, we hope that you'll be able to identify ways for identifying adult primary and specialty providers. You'll better understand an adult model of care and some of the resources Got Transition has available around transfer. You'll understand the contents of a transfer package to send to an adult provider. You'll be able to identify ways to communicate with and support adult practices. And finally, learn how Kentucky and Maryland care coordination programs plan and support the transfer to adult care for their youth with special health care needs. So again, on our website after this, you'll see handouts related to turning 18, guardianship and alternative decision-making supports, question to ask your doctor about healthcare transition, and an exciting new young adult online quiz. Kentucky has some exciting resources on their transition policy and their actual 18-year-old birthday card that they send out to parents and youth. And Maryland's Coordinating Center has their transfer package, their outreach package, and a handout on the delineation of roles. Next slide. So just to review with you what was in webinar 1, on that series, we laid out the clinical foundations for transition. We discussed various ways you could measure performance. We talked about the care coordination baseline results that we gathered from Title V agencies. And we talked about starting a healthcare transition policy and writing a name statement. Next slide. In the session 2, we reviewed the first part of the core elements, those related to policy, tracking, readiness assessment, and planning. And we talked about how the tools can be customized for various individuals with, for instance, intellectual and developmental diseases, disabilities, or other conditions. And we have those resources on our website. And we were pleased to showcase the work of Children's National Medical Center in DC. They have an exciting Parent Navigator program that has customized the 6 core elements. Next slide. So here we are today on transfer, and I'm just going to quickly go through some of the elements that the components of the transfer that are part of the 6 core elements. But first of all, here is what researchers and consumers tell us about what is success in transfer. An easy transfer is associated with feeling ready and considering that coordination between teams is good. And young adults say success is when patient is attending scheduled visits to adult care and not lost to follow-up, when building trusting relationships with an adult provider, when receiving continued attention for self-management, and when satisfied with the transfer process. Next slide. So in our package of the transfer of care and the 6 core elements, we talk about planning with youth and family for an optimal time for transfer. Most often that's between the ages of 18 and 21. We talk about assisting the youth and family in identifying an adult provider, completing the transfer package, and communicating with a new adult provider. We encourage transfer only when the young adult's condition is stable, and that there should be confirmation about what the pediatric provider's role is for care until the young adult makes their first visit to the adult practice. Next slide. Now, many ask us, what is an adult model of care? That's when preparing for an adult model of care includes meeting with your healthcare provider alone, practicing independent skills and self-care skills. There is quite a growing literature base showing the importance of time alone in terms of building independence. And at age 18, youth becomes a legal adult where medical information cannot be shared unless permission given. And again, here are some resources on this that describes an adult model of care. Next slide, please. Also, oftentimes, I like this, Leaving Never Never Land. The adult model of care is patient-centered, care is self-directed. Adult practices typically, in comparison to pediatric practices, have very limited resources for care coordination. And the role of adult primary and specialty doctors are often quite different in adult care than in pediatrics. Next slide. So in our transfer package, we would like to see a transfer letter, a final transition readiness assessment, a plan of care, an updated medical summary, and if needed, guardianship or health proxy documents, condition fact sheet, and evidence of communication with the adult provider about transfer. Next slide, please. Please know also, before we start with Kentucky, that we have sample resources for transfer packages in the core elements package on our website. So I'm just delighted to introduce Karen Rundall and Lee Gordon from the fine state of Kentucky. They are among a handful of states that score the highest in terms of implementing the 6 core elements and following evidence-informed approaches for transition. So we're really excited to hear more about Kentucky. So thank you very much, Karen and Lee.
Thank you, Peggy. As Peggy said, my name is Karen Rundle, and I am the Division Director of Clinical and Augmentative Services at the Kentucky Commission for Children with Special Healthcare Needs. And with me today is Lee Gordon. Lee?
And I am the Transition Administrator here at the Commission.
Next slide, please. I thought we would start off today by just taking a look at Kentucky and how the Commission offices are, where they're located in our state. All of the cities that are colored in blue are where our regional offices are located and where our full-time staff are housed. The cities that are labeled in red are satellite clinics, and that's where we have temporary clinics where we just may go for a day or a day and a half and have clinics with our specialists that come in from University of Kentucky to increase access in those areas. Next slide, please. So just to tell you a little bit about our care coordination, in fiscal year 2017, the Commission provided a little over 78,000 services to 9,148 unduplicated patients through specialty medical clinic programs and augmentative programs. We are one of few Commission programs that do provide direct care currently. Our staff mix includes registered nurses, social workers, administrative support staff, audiologists, speech-language pathologists, dietitians, and family support parents. Now, all of this staff is not located in every one of the offices. We have individual staff in the offices depending on the size of the offices and the clinics that are offered there. Many of our staff are housed in one office and then they travel out through their region when clinics are going on to provide services in that area. For example, our dietitians are located in the east in Moorhead and in the west in Louisville, but they travel out to clinics in the east and the west to provide services during clinics. we are looking at telehealth to decrease their travel time and increase access for those kids in those areas. Our registered nurses, our social workers, our support parents, and providers collaborate with patients and families during clinics to create the plan of care. This multidisciplinary team assists families and children with linking with needed medical and social resources to assist with transition, as well as overcoming financial, language, and cultural barriers. Next slide, please. The specialty programs that we currently have are autism disorder, cerebral palsy, cleft lip and palate, craniofacial anomalies, ophthalmology, cardiology, neurology, orthopedics, otology, audiology, and therapy services. The specialty clinics included currently fill gaps in medical care that exist in the regions where they're held. The Commission contracts with subspecialists from the University of Kentucky and the University of Louisville who travel to our regional offices and provide clinical services to the children enrolled in our programs. Programs can be added if a gap in services is demonstrated, and of course if a provider is available. Also, programs can be removed if services become available in that area and a gap no longer exists. Next slide, please.
Now, what I'm going to talk to you about is what some of the things Kentucky does related to the 6 core elements of healthcare transition. A transition policy, yes, the Commission, we developed a transition policy utilizing the transition policy example on the Got Transition website. And through our development of this, while we were working on the transition policy, we had our Youth Advisory Council review the policy and approve it prior to educating our staff about the policy. Our staff were informed about the policy and their role in the transition process. The policy was then posted in all 11 of our Commission clinics where it was visible to our patients and their parents. And the policy is mailed with the transition letter to all 14, 16, and 18-year-old patients on their birthday. And just to touch base on those 4 age groups, some items that are in our transition policy, and I'll just kind of go over a little bit of that, but not the whole policy. The Commission for Children with Special Healthcare Needs is committed to helping our patients make a smooth transition from pediatric to adult health care. This process involves working with youth beginning at ages 12 to 14 and their families to prepare for the change from pediatric model to care where parents make most of the decisions to an adult model care where patients take full responsibility for decision making. And at age 17, we will begin collaborating with the youth and families to prepare the youth to transfer to an adult provider. We recommend this transfer occurs at age 18 or at least before the youth is discharged at age 21. We will assist with this transfer process, including helping to identify an adult provider, sending medical records, portable medical summary, and communicating with an adult provider about the unique needs of our patients. And we also have a little bit in there about at age 18, the youth becomes an adult, and at that point, they're responsible for their health care, but the parents need to be aware of that, and that we will, in the birthday letter, we include information about release of information, consent for treatment, and notice of privacy. And our birthday letters, we not only send one to the youth at 18, but we also send a letter to the parent so that they're fully aware that those decisions are now the youth decisions without them giving, unless they give release. The next item here, registry. The Commission uses an electronic health record called CUP that all patient information is entered in. So that's our registry that we use that has patient information in it. Transition readiness assessment. The Commission uses a transition checklist in CUP as our readiness assessment. Staff enter transition progress notes to support the transition checklist as they meet with youth and families during the clinical process. Next slide, please. Next. Thank you. As far as transition planning, the Commission transition checklist focuses on age-appropriate transition questions for ages broken down 0 to 4, 5 to 11, 12 to 14, 15 to 17, and 18 to 21. Prior to age 18, youth are informed about the need to choose an adult health care provider when he/she turns 18, be familiar with health insurance and how it works, insurance plans, deductibles, co-pays, etc., and informed about the importance of organizing and keeping medical records and receipts. One of the things, if a young person is going to become responsible for their health care, they not only need to know about communicating with the physician, but they need to understand how health insurance works and how the payment process works and keeping up with their receipts so that they'll know how that is being paid for. Because if it doesn't get paid for, it's hard to get the care. Transfer of care. Our staff develop a portable medical summary that is given to patients to use upon transfer to an adult provider. And here in a few slides, Karen's going to talk a little bit more about that portable medical summary. We also, staff inform patients about the FEMA emergency preparedness brochure titled Preparing Makes Sense for People with Disabilities, and I have a link there with that. That not only helps the patient and family know about preparing for a medical emergency, but preparing for a disaster that may happen. So that's a good resource that our staff give to our patients and educate them about. And as far as transfer completion, to give us feedback on the services that we're providing, clinic surveys are completed by patients and family members during the clinic process while they're in clinic. And then also transition phone surveys are attempted with each commissioned patient after the patient turns 21 years old and ages out of the commission. And I do those phone calls myself to give us input on our services. Next slide, please. In 2014, the commission went through a strategic planning process. And during that strategic planning process, the commission developed standards of care. One of those standards of care was a transition standard, transition to adulthood. The standard, as reads, is the commission will provide high-quality transition support services to children and youth with special health care needs to assist them to make a successful transition to all aspects of adult life, including health care, education, employment, and independence to the full extent of their potential. And we have some bullets of some of the activities to help meet that standard, and I'll just mention a few as far as helping with transitioning to adult health care is providing information and patient education, linkage to needed services, facilitating access to service providers, and care coordinators services for children and youth during transition to adult health care. As far as the performance of evidence, patients and their families will attend clinics and be asked appropriate age group transition questions from the Commission Transition Checklist and CUP. Patient and their families' responses to the transition checklist questions will be documented in the medical record. Patient follow-up on referral services will be documented in the medical record. All transition support services will be documented in the patient record. Parents will participate in satisfaction surveys. Next slide, please. Here's just an overview of age-specific information timetable with focus on transition to adult health care. I've already mentioned the Commission Transition Checklist focuses on age-appropriate transition questions for ages beginning 0 to 4 all the way through 18 to 21. Beginning at age 12, questions are directed at the patient. Prior to that, the questions are directed to the parent. Below are some questions targeted at preparing the youth to transition to adult health care. So as far as the 12 to 14 age range, three of the questions I pulled off our checklist is, I understand my diagnosis and can explain it. I tell the doctor how I'm doing and answer questions. I take my medicine with or without supervision. So you're starting that young person to take responsibility for their care, to understand their diagnosis, to understand how their treatments are, so that they can start to become independent for their care. And you're also talking to that parent about the importance of that youth being educated and understanding their care, so that when they get to be an adult, to the extent possible, they can take care of their care, because the parents aren't going to be around forever. As far as 15 to 17, I talked with my doctor, nurse, social worker about the need to choose an adult healthcare provider when I turn 18. I am familiar with health insurance and how it works, health plans, deductibles, copays, etc. I understand the importance of organizing and keeping my medical records and receipts. I already touched on that earlier, but it's so important for the young person to understand that financial process, because if you have a young person who's wanting to move out on their own, or they move off to go to college, if they don't know that when they go to the doctor that they have a copay, and when they show up they're supposed to have $25 to pay the copay, then that's going to be a big shock to them, and then when they get there they won't be able to access their care. 18 to 21, I have plans for adult health care providers, and have made initial appointments to establish care with them or are already seeing them. And Karen's getting ready to talk to you about our process about recruiting physicians and making sure that we have adult physicians to transfer our young people to. So, thank you. Next slide, please.
Okay, just to talk a little bit about how we've recruited our physicians. We started a pilot back in 2013 out of our Moorhead office, and the ladies that you see in the picture there are the team in our Moorhead office. So we have spread from there on out through the state, and in the state of Kentucky, we've kind of identified 5 kinds of practices that are typical types of practices that we work with. The first one, and probably the most common one, is the family medical practice. And that's the practice where the whole family is going to the same medical practice. So the young person is staying within the same medical practice, and so it's just a matter of continuing to provide information. We do go ahead and complete the all of the information for the providers and give them that information as we would any other provider. We also have the second type of practice is the parents have an adult PCP and the child has a pediatrician, and so the child just kind of migrates over into the parent's adult PCP. So we have outreach to those doctors and talk to them about what the commission has to offer. And so the child feels, or the youth feels pretty comfortable with that practice because they're familiar with it as their parents go there. The third type is the federally qualified health center, and we outreach to those and get agreement with those physicians to provide care to our youth that have more complicated care. There is the medical centers that have adult health care clinics that we outreach to, and then there are the freestanding adult primary care provider offices. So our process is that our commission staff perform regular outreach to area provider offices and the federally qualified health centers to provide information regarding transitioning youth with special health care needs to adult care. And they talk to them about the care coordination that we will continue to provide between the ages of 18 and 21 when they actually do leave the commission, and the assistance that we can provide that can be supportive to not only the youth but to the physician during that time. The commission staff also attend community partner meetings and community health fairs where they learn a lot about new area providers, as well as they stay in touch with current community providers and they build relationships. Next slide, please. We have the portable medical summary, which is it's kind of a brief report of what's gone on with the individual as far as their specialty care. And so this is just some of the parts of that. It lives within our computer program, so some of the information just migrates over the demographic information, the child's name, what the child likes to be called, their date of birth, what kind of insurance they have, who's the legal guardian. We do list diagnosis, all the diagnosis that the child has come into the commission for during their time with us. We have an area where we type in a clinical summary, which is kind of a synopsis of things that we want the physician to know, or the family to know. We have an area for an emergency plan. We have an area for allergies, all medications that the youth is on, any specialists that the youth sees, their baseline vital signs, including their height, weight, BMI. There's a problem list with recommended actions. We have a to be avoided list. Also, surgeries that have been done, procedures that have been done, labs and diagnostics, any equipment, appliances, or assistive devices that they use, any medical monitors, or school community information. Next slide, please. There's an area also, it kind of shows up differently on this last slide, that we type in to provide information on special circumstances and comments that the family and youth want us to know. And in this last page, we get the signatures, the parent caregiver, the primary care, and the care coordinator. Next slide, please. So what did we learn? We've actually learned quite a bit about this. So as we started to outreach, we learned that you just don't walk into a physician's office any time of day. You know, you need to give them a call if you really want to be able to have a conversation and provide education. So you have to call the physician's practice for a good time and a good day to visit. It's best to try to connect with the physician's nurse or someone that works directly with the provider, and try to establish a relationship with that one contact person in the office. We've had good success. We have been able to build collaborative relationships with the adult providers where they contact us. They want to be sure that they're well informed about the youth specialty care, and it's worked out well in that regard. So we feel like that there are a lot of lessons learned. There's probably a lot more for us to learn, as we've only been doing this for a few years. Next slide.
Well, thank you very much, Karen and Lee, for this wonderful presentation about Kentucky's statewide efforts. And again, I think it's important to note that every a state Title V program looks a bit different. And as Karen mentioned, the state of Kentucky has focused a lot on direct delivery of services around specialty care and care coordination. So now it's my pleasure to turn it over to our Maryland Title V leaders. I'm Judd Miller and Mary Price, who are going to give some introductory remarks for Kathy Rivers.
Good afternoon. This is Mary Price. On behalf of the Maryland Department of Health, Office of Genetics and People with Special Health Care Needs, we send our greetings to all. And a special thanks to God Transitioning for showcasing one of our outstanding grantees who uses the 6 core elements in their best practice models in healthcare transition and care coordination. Our office is happy to introduce Dr. Kathy Rivers, Program Director from the Coordinating Center, to present on the Transitioning Connection Initiative, a project funded through our office Title V grant program. Without any further introduction, Dr. Kathy Rivers of the Coordinating Center. Thank you.
Hi, and good afternoon. I'm going to talk in a little bit more detail about the process of identifying and partnering with adult healthcare providers and how we do it at the Coordinating Center. Next slide, please. Now, there's an important difference. The Coordinating Center does not provide direct care. We provide care coordination services, mainly with nurses and social workers, to about 10,000 individuals in the state of Maryland. And our mission there is on the left. What we're trying to do is connect people with the services that will allow them to live meaningfully in their community and keep the best health. And part of that is transitions of care. Next slide, please. There are two programs that we have focused on with our grant. Both are funded by Maryland Medicaid. One is the REM, or Rare and Expensive Case Management Program, which provides as one of its services care coordination for people who meet diagnostic criteria with health needs that are rare in occurrence and expensive to treat, and serves about 4,200 people. 75% of them are less than 18. And then the Model Waiver Program is a smaller program, 200 children. They have to be identified as eligible before the age of 22 and not eligible for any other Medicaid programs. And they would need to be in a hospital if they were not provided with the services that can keep them in their home. And this all started because our care coordinators said, this is the biggest problem. One of the biggest problems we have is this whole healthcare transition issue, because it's often a crisis when somebody is not able to access care because they can no longer access their pediatric care and don't have an adult provider yet. Next, please. So as Mary said, TCI is funded by a systems development grant from our state, the state of Maryland Title V agency. And our goal was to improve the healthcare transition experience for the youth, their families, and the providers. And the biggest things we did was implement a 6 core elements model with customized tools for our REM and model waiver population, but ours is a care coordination model. A big part of our model is also provider outreach and recruitment of adult primary care providers. Next, please. So we started in 2015 with a pilot program, and the youths identified in the pilot were those with neurological disabilities and ventilator dependence. And we did a baseline survey and found that only 21% of the youth and families had received assistance identifying a new adult primary care provider. And as Peggy had said earlier, most transfers occurred between 18 and 21, but about a third of our clients over the age of 22 were still with pediatric primary care providers. And families wanted to know that transfer was coming, and they wanted to be part of the planning. And I know everybody here knows that transfer is not the same as transition. You know, the transition process of education should start a lot earlier and take a lot longer than the transfer process. So we do both at the coordinating center. Our providers, because we surveyed providers too, basically wanted training on childhood onset complex chronic illness management, especially neurodevelopmental disabilities, and the adult health challenges facing the long-term survivors of these childhood illnesses. Pediatricians wanted a list of adult providers. So did our care coordinators, so did the families, so did the Office of Genetics, our Title V agency. So that was a big request. But the adult providers mainly wanted more communication. They wanted a plan of care for the next year and support with adult disability resources. Next, please. Here are some of the comments. I'm not going to read them, but the one in the middle says, I need but never get a medical summary and a plan of care. If I had one, I could implement the plan while I'm getting to know the patient over the next year instead of having to start from scratch and remake the wheel. Okay, so we all realize that these youth come with extra services needed, extra time, extra paperwork, and we feel that our care coordinators, our care coordination model, can help the adult offices with those needs and help the youth and families to make the transfer process easier and better for everyone. Next, please. So we made a plan that we were going to identify the providers, engage them, get them interested, teach them about healthcare transition and about our population, support them in the transfer and integration into adult healthcare model, and also we're going to recruit more of them so that there would be more adult primary care providers for youth to be able to go to. Next, please. Okay, this is how we identified them, and I'm going to call it starting the list. We have an internal database that we call Karma, and our clients are all listed in terms of who all their primary and specialty care providers are. So the first thing we did was took the pilot list and said, well, who are they seeing now? Who are their pediatric providers and their adult providers? And of those adult providers, which ones are med peds and family med providers? We were looking for adult providers that already were connected to and seeing adults with special healthcare needs, young adults with special healthcare needs. And then we would look and see who else was in their practice. Who in their practice is accepting new patients, who has a special interest in teens and youth and young adults, who has a special interest in youth who need complicated care. Just like Karen did, we asked the parents whether their own primary care providers would be willing to see their youth. We went to pediatricians' offices and said, well, who are you referring to? We found, because we have training programs, our pilot was in the Baltimore area, that med peds providers are very well suited to care for this population. As a matter of fact, one of the med peds providers in our area wanted her primary care clinic to be all youth with special health care needs and intellectual and developmental disabilities. Geriatricians, because they are used to both people who are on multiple medications and having a complex care list, and also are used to people coming in with a caregiver, are also very comfortable with our population. We tried to be involved with educational outreach, both in the primary care office and in CME events that were occurring in the area. We sent out notices to our local American Academy of Family Practice and the American College of Physicians, networked with organizations that are also interested in youth with special healthcare needs, and specifically with healthcare transition. And I also found, as Kentucky did, that if I could identify one person in the office who ran the place, I'll call that the office manager, and ask to be transferred to the office manager and speak with them, they would often identify integrating young adults with special healthcare needs as something they could use support on, if not a problem for their practice, and would say, if you can come with help, yes, I will have you speak to my providers. But it's real difficult to get your toe in the door. I mean, these are busy people. They may not want to take on extra work. And when I specifically spoke with the providers, one of the big things they said to me was, but I don't want my name on a list, because they were afraid they were going to be overwhelmed. Next slide, please. So I've mentioned before, we did outreach and educational events. We also did a provider packet, and you have that in your handouts, and it was information about our care coordination services, healthcare transition educational services, local and state and national adult disability resources. So it was a useful packet of information for them. I would go to their office. I met one internist at the group home when he was seeing patients. I would go to provider events. I'd be willing to call or email, or Hopkins, I participated in an ECHO that was also a grant by Title V to outreach to community physicians. I would contact them whenever it was most convenient for them, which was usually after office hours. Often, if I dropped off a packet and a provider took a look through it, then I'd get a phone call back saying, tell me more, because they found it interesting. And again, we surveyed all the existing providers in our pilot, and those are just some of the ways. We tried many, many, many ways, and it was an uphill battle trying to get in the offices often. Next, please. Then when we met with them, we talked about healthcare transition, what it meant to our REM, Youth in the REM and Model Waiver Program, the 6 core elements approach. We asked them, what are you doing to integrate these youth into your practice? Are you having any issues? Do you have any specific needs? Many times I could access multiple providers at the same time by agreeing to do a brief staff meeting, because the in-hospital network practices would have a requirement to do a brief continuing education part at their monthly staff meetings. And so I would fulfill that need, plus get to access all the providers that were there. Next, please. I just wanted to call notice to a book that Peggy and Patience did the first chapter called Care of Adults with Chronic Childhood Conditions. And this is a resource because, again, these doctors, many of them have not had any training in youth who have survived complex chronic illness of childhood and then survived into adulthood. And they're surviving because they're getting better medical care, better care in their communities, more support, and they're living into adulthood and growing up and starting to have adult problems. But these are just some of the training requests. What we'd like to do someday is do more education around, say, pediatric neurodevelopmental disorders or mental or behavioral health needs, but we haven't quite gotten there yet. We do it on a one-by-one basis when providers ask us to. Next, please. And then the support we give comes through the care coordinators. So what I did was I trained our staff in how they are going to carry out a healthcare transition program. And it's a 6 core element approach. I'm not going to go into detail about it. It looks very much like other 6 core elements approaches, except that we pay special attention to legal needs, to forming that medical summary and emergency care plan, and to the identification and the transfer visit, helping youth to even schedule the appointments, get to the appointments, making sure they're going to stay. So the benefits to the adult providers are we do healthcare transition education with our youth and families so that they are readier by the age of 22 for the adult model of care. We support the integration into the practice. We help the adult providers with resources such as adult subspecialty resources and disability resources. And we as well have a transfer package that includes all the things that both Peggy and Karen had talked about that are important for an adult provider to be able to hit the ground running and know as much as they can about the patient as they're starting. The other thing that we can do that makes us a little different is that the care coordinator, you don't age out of your care coordinator. They're there when you're in the pediatric office and they're there when you're in the adult model of care. So they provide, if you will, a bridge between to connect the pediatric and the adult providers, and also a link back to the pediatric provider if the adult provider has a question. So some of the things we're trying to improve in our transfer package are to get the pediatric provider to identify the top 3 need to know for that the adult provider would really be helped by knowing this about this client. But there is some back and forth communication going, and we're trying to improve that. Next, please. And we're trying to increase the number of adult providers. We're trying to grow the list by all of these mechanisms. We're asking both providers and clients and families to give us feedback so that we can improve our program. We are able to collect data on our performance, and those are things like how many of our youth have transferred. When we started with the pilot in 2015, about 30% of our clients were over the age of 22 were still with pediatric providers. Now we're at 13%, which, granted, they've gotten a couple years older too, but also we found that many of those pediatric providers are what we're calling pediatric extended providers. They're adolescent clinics that go to 26, or pediatricians that have agreed to keep them forever. So it isn't like they have no plan, but now we're working with them on a backup plan. Well, what are you going to do when you have to move? Are you sure you're accessing all your adult disability resources? I also spend a lot of time collaborating with other transition leaders and champions within the state of Maryland on systems change. And we, I think, are doing a great job, led by Mary, of sharing resources, so we don't all have to remake the wheel. What I would love to see is if healthcare transition would be part of the medical curriculum so that it wouldn't be a surprise to the providers. It would be something that they learn about as they come up, and everyone knows the importance of it and how to do that in their specialty. Next, please. And that's it.
Well, thank you so much, Kathy and Karen and Lee. I think that we heard a kind of a awesome presentations about statewide care coordination programs that have really built a foundation with a grounding in transition preparation, but really a very careful plan for transfer to adult care, ensuring that warm handoff, that sharing of medical information, and the continuity of care coordination. I think it's fair to say that a lot of states retain their youth till they're 21, and often when the young person leaves the care coordination program at 21, they're also leaving their pediatric provider. So the way that both of these programs have sequenced their transfer, I think, offers some important opportunities. I'd like to, I've got a few questions that have come through, and Samantha.
Sure. So the first question is for Lee or Karen, and it says, I would like to hear what communication the Bureau staff have with pediatric primary and specialty care providers to identify adult providers, and what they do if the providers have not been working on transfer planning and don't know adult provider options.
Pediatric. Their conversation with pediatric providers?
Yes, pediatric pediatric primary and specialty care providers.
Well, with the specialty care providers, the care that they get through the commission is the specialty care provider. So we work very closely with the specialty, and then as they start to near 18 or 21, probably 21, they would age out of the commission. They would be interested in going into an adult specialty provider. So we have worked with them through our program to assist them, and we talk to their to the pediatric specialty provider to get a referral as to who they think would be the better adult practice specialty provider, and also it may be someone in their own practice where they have pediatric and also adult specialists. So we kind of work with our specialists in the commission over time to prepare for that adult specialist. And then once they are ready to make that transfer, then we assist them, you know, to transfer into that adult practice through providing the information and support as we would. With the pediatrician, we actually haven't had, and that's one thing we can improve on, we haven't had a lot of contact with the pediatrician or outreach to the pediatricians. We have focused mostly on the youth to teach them to talk to the physician, to understand their insurance, to understand how to make an appointment, to really understand those areas that they need to manage independently to transfer to adult care. And then we try to assist them in identifying an adult health care provider, and if they need us to go to that first visit of an adult health care provider, our care coordinators would go.
A follow-up question to that was, what if the pediatric providers do not know of adult care providers?
And probably in a lot of instances, they would not have a referral, but our nurses out in the regional offices, they outreach in their areas, and so more than likely they have a good referral sources that they can talk to the family about, that they have physicians in their regions that are willing to accept youth with complex needs into their practice.
I think it's fair to say that both of these programs have invested in a huge amount of effort into outreach and nurturing the relationships with the adult provider community, and I'm certain that this effort can't be understated in terms of its importance, and to set systems improvements up so that it's not just the individual pediatric practice to find the adult provider. is really important to have your system support. And I'm wondering, Kathy and Karen, if you can comment on the time between the last pediatric visit and the initial adult visit. Have you found that that should be really compressed, or how do you work that out?
I think we individually base it. I think the more complex the care needed for the youth, I mean, some of the youth routinely come in every 3 months to see their provider just to make sure that everything is going okay, and that the provider has a good handle on everything that's happening there. We often suggest to the adult providers that they see the youth more frequently in the beginning of the relationship as they get to know them, rather than say, just come back in a year. But a lot of it depends on the complexity of the youth and also what kind of needs they have. So I don't have a standard answer for that, Peggy. I would imagine that sooner is better than longer, because you worry that if it goes too long that they're going to lose some kind of access to care or resources or prescriptions or something that they need.
Great.
All right, and this is another question for Karen. Would you be willing to share the 0 to 21 breakdown of questions?
For our transition checklist?
Yes.
Yes.
Absolutely.
Okay, so we will make that available on our website. The next question says, do you have resources to share with other states to assist our Children with Special Health Care Needs program at a county level to improve the transition process?
I would assume that we could use the same methods and program on a county level as we can on a regional level.
All right. The next question says, for Maryland, how important is the outreach to adult providers to be conducted by a physician versus a non-physician? If you have other non-physician staff members who are engaging adult providers, is there a difference in the reception they receive by those doctors? I'm trying to get to the impact of physician-physician communication for the initial conversation.
I have to say that when I utilize the MD card, it makes the calling in and getting to somebody who can talk to me much easier. So it does open doors. I think it was harder when much of that was done by our transition specialist. And I'm sorry to say that. And I feel rather guilty about calling in and saying, this is Dr. Kathy Rivers. May I speak to Dr. So-and-so, and not immediately identifying what I'm calling for. I find that many of the staff in adult providers' offices throw up real walls because they're trying to protect their provider from having to do more work, especially work that, isn't compensated, or we're still working out how things are being compensated. So I think it helps, but I also think a lot of it is personality. I'm fairly outgoing. I don't mind walking up to people and networking with people, and I get very excited and passionate about the subject. I'm a special needs parent myself, so that I don't know how much of it is the MD and how much of it is just the energy level. I think you have to have somebody who's really interested in the topic going out and doing it too. It's very easy when you're out doing outreach for people to raise up all the negatives and all the barriers and all the problems. And I try to keep it positive. I try to keep it about solutions. I'm always looking around to see who's really interested, nodding and shaking their head and looking at me versus the people who are checking their phone during big meetings. But I think it does help. I don't think it's essential. And certainly my care coordinators, right now our program's reaching about 1,625 youth in the transition age, and there's about 100 care coordinators working with those youth. Some have a lot in the age and some don't have many in the age, but they're out there in the trenches. They're speaking with the pediatric providers and the adult providers and their office staff, and they carry far more of the weight of it, of being the face of, we come to help. You know, we're trying to help you with solutions here. Tell us about your problems and let us see if we can figure out a way to solve it. Hope that helped.
Yes. The next question reads, how have you overcome the reimbursement issue as many are on Medicaid plans, possibly Medicare?
This is Kathy. All of the youth in our REM and model waiver program are Medicaid funded. Our model waiver program, it's the secondary funder, but still, so all the providers they utilize have to accept Medicaid, and that limits our provider lists. Obviously, it's something we're always looking for. When they get Medicare, then they lose and some of them do at a young age due to their parents, getting disability or something like that, then they lose the care coordination piece of the process because they move into Medicare rather than the REM or the model waiver program. But insurance is a big deal of it. This is, a lot of providers are doing this out of the goodness of their hearts. You know, they are doing it because it's the right thing to do, not necessarily because it fits cleanly into a 10-minute office slot, because it never does. And the more we can help with care coordination support, the more we can help them provide this care. And I'll turn it to Karen and see what she has to say about it too.
Kathy, I don't think I have anything further to say. I agree with what you presented.
This is Peg. Also, I'd just like to let the audience know on our website we have a coding and reimbursement tip sheet. It's for 2017. Our new one will be coming out in probably another week or so. But there are options through health home options, targeted case management in Medicaid, and there are certain billing codes. The challenge is a lot of payers don't recognize it. So I think we fully understand the challenges with reimbursement.
The next question says, can you give us an idea of what are the top things the adult providers request?
They want a medical summary, an emergency care plan, a plan of care for the next year, and communication with the sending provider. That's and then secondary to that, they want then they want adult disability resources, because they know the medical stuff. But when it comes to the issues that many of our families have with housing, with utilities, with transportation, with DME and DMS supplies, that they don't have the knowledge of, and the care coordination can help them with that, let alone vision, dental, a whole host. Mental and behavioral health is huge and not something that we have a good handle on either. It's just there's not a lot of resources. Then the continuing education piece.
Great. Karen, do you have anything to add to that?
I think Kathy's covered that. All of the physicians want more than just the physician's dictation. When they want audiology reports, social reports, care coordination reports, plans of care, everything that Kathy mentioned. They really want to be well educated about the plan of care for the patient and the future plan.
All right, the next question says, for either state program, is there a specific buy-in used when recruiting adult primary care providers and specialty providers willing to see complex pediatric patients? And does the question of finance or reimbursement frequently rise? And if so, what is the response?
Nothing like saving the best for last.
We don't have special buy-in that I'm aware of for Medicaid, people who have Medicaid as their insurance in Maryland. I know there's a lot of talk about the complex care management going on all over the country and reimbursement, but I haven't seen anything actually happening or heard of it.
Yes. I think in kind of closing up, the gut transition has been funded by the Packard Foundation to convene a transition payment roundtable. And we're having our meeting on May 8th, coming up with a set of, I think, very practical strategies for payment. And we're meeting with commercial and Medicaid payers, and hopefully out of that, some new ideas will be shared with all of you and some interest among payers to address this highly important issue. So I want to, again, thank you very much, Karen and Lee and Kathy and Mary, for participating in our webinar series. If we could just advance to the next slide so I could give you a promo about the following final two. In May 31st, we're going to have a session on integrating into adult care. This is really, we've kind of flipped the bridge now, we're on the adult side. And then our final and very special one will be about youth, young adult, and parent engagement in the transition process. So thank you all for joining us, and I hope you have a lovely evening and rest of the week.